These are my disclosures. Again, thank you all for joining us today. I'm asked to talk to you about a very exciting topic, which is RFA for intraductal cholangiocarcinoma. As you know, cholangiocarcinoma is one of the really poorest prognosis cancers we treat. About 30% of patients or less undergo surgery. So 70% of patients are left, for palliative treatment, and they come to see us for that reason. If we talk about the patients who end up in our clinic and our practice, it's a little bit less than that. So if you look at this here, the cancer registry, approximately the 7% is the 5-year survival. And it's a little bit better than what we see for pancreas cancer. So this is a very difficult disease with really poor prognosis. Knowing your anatomy is very important. Obviously, hilar stricture and hilar cholangiocarcinomas are harder to treat than patients with other types of cholangiocarcinomas. This is what we call Klatskin tumors, and they can be classified based on the Bismuth-Collet classification to 4 different types. 1 and 2 are the ones just below the hilum. 3A and 3B are the ones that go into the left and the right intrahepatic duct, and 4 is the type that involves segments inside the liver. So typically, when you're an endoscopist treating patients with cholangiocarcinoma, you want to think about it as this is a proximal malignant biliary duct stricture. For distal malignant biliary duct stricture, usually it's pancreas cancer. Sometimes a different type of cancers. About 70%, 80% is pancreas cancer, but sometimes you're dealing with ampullary cancer. Sometimes you're dealing with, mets to the liver or the portal hepatic area compressing on the bile duct. But the bottom line is our job is to drain those bile ducts. And back in the 90s, we used to do most of the plastic stents was the preferred method. Nowadays, we do some combination of self-expandable metal stents and plastic stents. And the metal stents have some advantage, but however, they have some disadvantage. Tumor ingrowth is one of them. Sometimes you can have a biofilm leading to cholangitis, and you can have tumor ingrowth or tumor debris and sludge leading to need to re-intervene early for the bile ducts. So it's very simple. You want to think about where the problem is, and our job as ERCP or endoscopists is to drain the bile ducts. And hopefully you can drain the bile ducts, decompress the liver as long as possible. And that's what we're going to focus today, is one of the tools that will help you achieve that. And it's radiofrequency ablation. So RFA, as you know, it delivers focal hyperthermia that leads to tumor microenvironment alteration, which as a result leads to tissue destruction. We are quite familiar with RFA. We use for different types in different disease and different conditions inside GI field and outside GI. For example, in Barrett's esophagus, RFA is known to help with dysplastic Barrett's. As a matter of fact, one of the early studies in 2009 was published in the New England Journal, and Dr. Muthasamy was part of that pivotal study that showed that RFA really is safe and effective for dysplastic Barrett's, reducing progression of disease. We also know that RFA fits nicely in patients who have early disease in terms of high-grade dysplasia or early or low-grade dysplasia, but not for patients with cancer, because RFA can reach about 500 to 700 micrometers in the esophagus. So that's a little bit better than high-grade dysplasia, but not as deep as you can do with EMR or ESD. As Dr. Siddiqui mentioned, RFA in the pancreas is kind of a new topic. There are a few studies on it. This study, there is a new probe for it. It uses 19-gauge needle. You get into the pancreas lesion and you do RFA ablation. However, you have to be careful with this because pancreas is always a little bit more sensitive. And some studies showed some benefit. For example, this study of 12 patients or 14 neuroendocrine tumors, 86% resolution. Other studies in pancreas cyst showed some resolution, but I think we need further and longer-term studies to really reach prime time for the pancreas cyst. So now let's focus on the biliary indication and going back to the basics. Why does this work? I tried to find some studies on the pathophysiology on RFA use in biliary, and I really did not find a lot. I only found those 2 interesting studies. And the first one looked at 2 different diseases, HCC and patients with colon cancer metastasizing to the liver. And basically, RFA leads to a dramatic increase in T-cell lymphocytes, measured by interferon gamma in this case, and cytokine release. After 4 weeks and 8 weeks, there's significant increase in T lymphocytes in the tumor around the RFA. Another study looked at the immunoresponse, and it showed an increase in IgG and in the T cells produced by the RFA. So RFA probably induces some immune response in that area that will lead to further benefit from stenting or whatever treatment you need to do. So what's the data behind RFA for biliary cancer? Early studies about 12 years ago or so showed some benefit. So this study came from the Hammersmith group in England, looked at 22 patients with malignant bile duct stricture, and one patient had pancreatitis, two patients had cholecystitis. Those were the adverse events, but a lot of patients had improvement in their strictures after using RFA. After that, multiple studies, observational and case cohort studies came out, and we have two meta-analyses we can review that summarize a lot of those studies. So this is the first one that came in 2020, earlier this year, looked at 13 studies, 1,339 patients. 5 of those studies were randomized clinical trial, and this studies included patients who had PTC, so it's not only ERCP, but also some PTC. So the graph on your left side shows the stent patency. And as you see, RFA in blue color with stent led to a further or a higher patency, longer patency of stent compared to stenting alone. So that's actually very nice to see. And in terms of overall survival, RFA plus stenting showed better survival as well in this meta-analysis. However, I would like to bring to your attention that there was significant heterogeneity in the studies involved in this, meaning that the outcomes were variable between the studies. So when you look at those studies, you have to be careful when you analyze it, especially for overall survival, before you draw conclusions. But for stent patency, clearly this meta-analysis showed that stent patency is better when you do RFA plus stenting versus stenting alone. Another meta-analysis came out about a year ago, last year, and it included a little bit more studies, 17 studies, but only 3 of them were randomized clinical trials, and also looked at the same primary outcomes, patency of the stent and survival. And this meta-analysis also looked at the underlying malignancy type. And similarly, it showed improvement in overall survival and improvement in pooled stent patency by approximately 45 days for stent plus RFA versus stent alone. So this is great. Those two meta-analyses showing that overall survival has improved and stent patency has improved. What are the adverse events? Now, we know there are adverse events anytime we do ERCP, and those are known for ERCP. For example, pancreatitis seems to be similar with or without RFA. Abdominal pain is a little bit higher with RFA. But however, I want to draw your attention to cholecystitis, and this is an important adverse event, especially if you do RFA and you include the cystic duct. So if the tumor is including the cystic duct or involving or close enough, you will have to include part of the cystic duct. So that leads to a little bit higher risk of cholecystitis. So you need to be mindful of that when you're planning your procedure and looking at your patient. So this is great, two meta-analysis. However, I want to make sure that we know that I think we need more studies. So for example, since this meta-analysis, more studies came out, and this is a really nicely done randomized clinical trial from the Czech Republic, looked at 161 patients, including both cholangiocarcinoma and pancreatic cancer. And this study summarized in this graph, the yellow one is the RFA and the blue one is the control, and showed no benefit in survival and no benefit in stent patency. So more studies are needed before we know for sure that RFA will improve survival and draw definite conclusions. So how is it done? This is the infamous Habib probe, and this is this is a nice RFA probe that's made in a small factory in France. And I was told that 3 people produce this probe every day, all day long. So if one of them gets sick, there will be some delays. And Nagi Habib is a surgeon, so he, used this probe that was a surgical instrument, and he modified it for endoscopic use. And this is something that, in my early career, I'll tell you, this is something I really love seeing, because a lot of our endoscopic or surgical endoscopic techniques or tools are modified from surgical tools, and they tend to work very well. And Firas Bahdi, one of our fellows, published a nice report on this concept of modifying surgical approach to endoscopic approach, and really it's a nice story if you look at it over the last 4 years or 50 years. So this probe is 8 French, and you place it over a wire, you determine where you want to go, and it has 2 electrodes. Every one of them is 8 millimeters and spaced by 8 millimeters in between, and they are redupic, so you can see them under fluoroscopy. And this is the technique for the RFA. It's very simple. So most of our ERCPs are nowadays done under general anesthesia. You obviously will have to have a sphincterotomy to be able to do what you do. If you have stent, you'll remove the stent. Strongly encourage you to get a really nice cholangiogram, characterize your stricture, see exactly where the problem is. And of course, you don't want to opacify the areas that you're not going to drain. It's nice to do a cholangioscopy before you, so you put the spyglass and you take a look at the stricture, and then you place the wire, and over the wire you go with the RFA, and you apply the RFA with the electrosurgical generator. It used to be the Rita generator. Now you can use it with different types. With the Irby, you can get the same RFA production, and you go with the 7 watts for the intrahepatic ducts. Now the extrahepatic ducts you can do the 10 watts, a little bit higher, and the ampulla you can do 10 watts. And you usually do 90 seconds, and then you give about 1 minute break in between the two, and then you repeat it. And then it's nice to do a cholangioscopy after that and see the response. This is a nice picture. So you get your wire to the right, you ablate the right, you get the wire to the left, you ablate the left if you're dealing with a Hylar 3, with a bismuth 3 stricture. And if you want to think about it, how much energy you're producing a lot of energy with the 7 watts, but you also want to see how much you're including. So the 7 watts will usually lead to about 7 millimeters diameter of energy or impact. And 7 millimeters looks, sounds a lot, but if you think about the probe is 8 French, so that's 2.67 millimeter on both ends. You end up with about 2.15 millimeter of energy produced around it, and that's the effect that you're getting around the cancer area with the RFA. And always be mindful of adverse events. We mentioned that a little bit, but just remember, prepare for them. Talk to your patients about adverse events. I would encourage giving IV antibiotics before. I hydrate the patient very well, and also maintain close follow-up after, and use anything you can do in your practice to prevent post-ERCP pancreatitis. So what are areas for future studies? I think we need more studies on, first of all, to confirm the improvement in overall survival. We still need to get a little bit larger multi-center studies on that. I think we need more studies on disease biology and disease specifics. So it looks like this works for both intrahepatic and extrahepatic, but extrahepatic pancreatic cancer, why is it beneficial there? What can we do to make it more beneficial for a certain type of cancers or certain locations? So I think more disease-specific studies will be needed, and collaboration. We're really lucky here at UCLA to have our GI oncology. We have a very robust GI oncology team, and they do a lot of studies, and we like to collaborate with them. I think including some chemoradiation therapy along as a modality with the ablation might be something nice to do. Unfortunately, a lot of the times when those patients get to the point that they need palliative therapy, they're not surgical candidates. They've already done a course of chemotherapy, and they're left with really nothing but the endoscopist draining the bile ducts. But more collaborative work probably will give the patients a little bit better outcomes, given how bad their disease is. So as a conclusion, I hope I convinced you that RFA is safe and effective method. It seems to improve stent patency. It might improve overall survival. So if you do ERCPs, I encourage you to incorporate RFA into your practice. It's one of the tools that you can add to your arsenals. And if you'd like to talk more about this, please come and find me after, and I'll be happy to collaborate and discuss this further. Thank you for your attention.